Ladies and gentlemen, thank you for standing by. Welcome to the Health for a Change webinar. During the presentation, all participants will be in a listen-only mode. Should you wish to ask a question during the presentation, please use the chat feature located in the lower left-hand corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Wednesday, January 20th, 2016. I would now like to turn the conference over to Rochelle Seeger. Please go ahead.
Good afternoon. Thank you so much for joining us today. My name is Rochelle Seeger. I'm the Community Health Research Officer here at the Foundation for a Healthy Kentucky. We're glad you're here with us today on this Health for a Change training series. This free series is comprised of webinars and in-person workshops designed to support the efforts of Kentucky's community health coalitions, agencies, health advocates, and other interested community members. I'd like to begin today's webinar with a brief introduction to the Foundation for a Healthy Kentucky. We were founded in 2001 with a mission to address the unmet health care needs of Kentuckians. We do this through efforts to improve access to care, reduce health risks and disparities, and promote health equity. The Foundation currently has two initiatives. First, on promoting responsive health policy, which aims to make public policy more responsive to the health and health care needs of the people of Kentucky. Our second initiative, Investing in Kentucky's Future, aims to reduce the risk that today's school-age children will develop chronic diseases as they grow into adults. The Foundation fulfills its mission through a variety of activities, including grant making, supporting targeted research, and convening key stakeholders, providing policymakers with information needed to make decisions which impact the health of Kentuckians, and by offering training and technical assistance just like this event here today. We're glad you're with us. I want to direct you to the Foundation's website, healthy-ky.org. On our website, you can find archives of past Health for Change trainings, their webinars, Foundation reports, issue briefs, and upcoming event schedule. The Foundation for a Healthy Kentucky also maintains a second website, kentuckyhealthfacts.org, with health data about Kentucky communities and also county-level health data. Today's presentation, Understanding 1115 and 1332 waivers, is an important and timely topic. As you know, let's see. We're going to be talking about these Medicaid waivers. We have a guest speaker, Deborah Backrack from Manat Health Solutions, who will be discussing these two types of waivers. As we know, Governor Bevin announced on December 30th that he will seek to reform Kentucky's Medicaid program with a special interest in changing Medicaid expansion through waiver options. Today we'll hear about these two waiver options that Governor Bevin has indicated he may use to change the way Medicaid healthcare services delivered and paid in Kentucky. As our operator mentioned, all the participant lines are muted. You can submit questions via a chat feature there on your computer screen, and we'll have question and answer sessions at the end. Thank you to Deborah and her organization for allowing us to offer these slides for you. They'll be posted to the Foundation's website in just a few days. Now I'm very honored to introduce Deborah Backrack with Manat Health Solutions. Deborah, welcome to the call. Thank you so much for joining us.
Thank you so much, and it's a pleasure to be here. And thank you particularly to the Foundation for supporting this effort. I'm Deborah Backrack. My colleague Patty Bouzang could not do this call, but just let me give you a minute or two of background on me and Manat, just so you know where we're coming from. I've been a Medicaid groupie, if you will, for most of my professional career. And from 2007 until 2010, I was New York's Medicaid director. I came back to Manat in 2011. I'd been here previously, where my practice, along with Patty's, is very focused on Medicaid and Medicaid reform, and particularly Medicaid expansion. So we have worked with many states, including Kentucky, but we helped devise the Arkansas alternative waiver, New Hampshire, Montana. We're working in Michigan, Virginia, as well as Oregon and Washington. So we work with states and with stakeholders in reforming Medicaid, particularly around Medicaid expansion, and more recently been looking at 1332 waivers. So the Foundation asked us today to look at reforming Medicaid through the lens, in some sense, of what your new governor is talking about, which is alternative Medicaid expansions, ways he might want to expand Medicaid. So if we could move to the next slide, because I think you guys are moving it. Yes. So basically what I'm going to do is most of this time I want to talk about 1115 waivers. What are the features that other states have used? And I'll particularly talk about Indiana because I know Governor Bevins has looked at Indiana in terms of what we call alternative expansions. We want to just briefly sort of put out there that reforming Medicaid is also about payment and delivery reform. And just a few slides here because we do think that's part of the conversation, and then briefly touch on state innovation waivers. So let's go on to slide 4. And as I suspect, next slide please, many of you know, if the state wanted to do a straightforward expansion, which is what Kentucky initially did, you don't need a waiver. But if you want to add certain features that would otherwise not be permissible under federal law, the state must seek an 1115 waiver. The state has to show that it's budget neutral. It's then granted for up to 5 years. Sometimes it's 3, frequently it's 5. And the whole waiver approval process is subject to public transparency requirements, which means a lot about posting the application on a website, making it available, holding public hearings. So in the next slide, we wanted to just call out the 6 states that have used alternative mechanisms or 1115 waivers to expand. We've highlighted those states. Sometimes we also call out Pennsylvania, which had a waiver approved, but when the new governor came in, he decided to use the sort of straightforward pathway for expansion, so he abandoned it. But we do know from looking at that waiver some of the additional information on what CMS will and will not approve in an alternative expansion. So in the next slide, what we do is we just tick off the features that we're seeing in alternative expansions. And I'm going to discuss each of these, so I don't want to stop on this page and read a list to you. But these are the features that we've picked up in one of the 6 states or in Pennsylvania. So let's go to the next slide and kick it right off with premiums. Under federal law, premiums cannot be charged for individuals below 150% of the federal poverty level. So that's your expansion group, right? Because your expansion goes to 138. But CMS, starting with Iowa, has permitted premiums to be charged through a waiver. But it has never conditioned coverage on payment below 100%. So when you think about charging premiums, CMS is reluctant extremely below 50%. Between 50 and 100, CMS has only approved waivers, and it's worth looking at Montana's for this one. But between 50 and 100, CMS has only approved premiums when they are not a condition of coverage. So failure to pay results in a debt to the state. It does not influence coverage. And if your CMS generally does not permit copays to also be applied. There's some wiggle room there, but it is not excited about, to use the vernacular here, premiums and copays for individuals between 50 and 100. If the state wants to do premiums, the ability to charge copays is quite limited. And we give the example here of Iowa, which is a state that was really early on, was the first state where CMS granted the state the ability to charge premiums. You can see between 50 and 100 it was $5. And the result of non-payment was a debt to the state. They had no co-payments except for non-emergency use of the ER. But you're going to want to look at Montana here because it's a slightly different variation on the theme for the 50 to 100s. And then above 100, the state charged up to $10 the individual could be disenrolled, but they could re-enroll immediately upon certifying a hardship or non-payment. But they could also just certify a hardship, and they would get the exemption, and then it was a debt to the state. So as you think about premiums, and as the governor is thinking about premiums, it's worth thinking about it in 3 blocks: 0 to 50, 50 to 100, 100 to 138. CMS has never permitted premiums higher than 2% of household income. And the reason CMS fixed on 2% is because that is the amount of premium an individual has to pay in the exchange if the state hasn't expanded. So if a state hasn't expanded and someone whose income is 110% of the federal poverty level goes into the exchange, they're subject to a 2% premium. So CMS has never permitted premiums above 2%. Before we go to Indiana, which is our next slide, I just want to mention, I want to walk you through Montana. So in Montana, no premiums, no cost sharing below 50%, or for the medically frail. Between 50 and 100 in Montana, there's a premium, and it's 2% of household income. Penalty for non-payment is a debt, and that premium payment is offset against future cost sharing. So let's assume that your premium came out to $10 for the year. That's $120. Your first $120 of cost sharing is forgiven, or it's applied against. So what you're seeing in the 50 to 100 is a reluctance on CMS's part to couple cost sharing and premiums. Then above 100%, individuals are disenrolled if they fail to pay for 90 days, but they can re-enroll immediately upon payment of the back due premiums, or as soon as there's an assessment by the Department of Revenue, which has to happen quarterly. So we're going to contrast that. Remember, Montana comes post Indiana. In Montana, CMS walked back from the penalties it approved in Indiana. So let's go to Indiana. And again, I know the governor has looked at Indiana, so I think this is worth looking at. So in Indiana, everyone is subject to 2% premium. So even if you're making, $1,000 a year, it's 2% of your household income, unless you're less than 5%, and then it's only a $1. Now, below 100, so no distinction in Indiana between, individuals below 50. It's everyone below 100. Below 100, if you don't pay your premiums, you still get coverage, but you get a less generous benefit package. You get the minimum required. You get the alternative benefit plan minimum, but if you pay premiums, you get dental and vision. If you don't pay premiums, you don't get dental and vision. And you can see here, it says subject to Medicaid cost sharing, but the only Medicaid cost sharing in Indiana is for non-emergency use of the emergency room. So you're seeing here below 100, 2%, very limited copay, and no loss of coverage. You simply lose vision and dental, simply in quotes. Above 100%, and here's where Indiana has an onerous standard, which is between 100 and 138. After 60 days, you're disenrolled. If you haven't paid for 60 days, you're disenrolled, and you cannot re-enroll for 6 months. Even if you're willing to and are able to pay the back pay, you cannot disenroll. At the end of 6 months, you can re-enroll, but you don't have to pay the unpaid amount. So Indiana's the most onerous. Montana came afterwards, so you're going to want to look at both if you're having a premiums discussion. Let's save questions to the end. I'm not going to take as much time on all the other issues, and move to health savings-like accounts. Health savings-like accounts are of great interest to states. They are generally, I think we flipped. Did I miss cost sharing, or did you flip? Did I flip? Yep, cost sharing. My mistake. Let's go to cost sharing on slide 9. For cost sharing, CMS has rules about how much can be charged. Below 100, it's generally no more than $4 or $8. above 100% of the FPL, it can be as much as 10% of the cost of services. Below 100%, failure to pay cost sharing cannot deny you access to services. There is a special provision of law which makes it very difficult to waive the cost sharing rule. CMS has decided that special provision doesn't apply for premiums, hence you see all these waivers of premiums, but it does apply to cost sharing, and only one state, Indiana, has gotten a waiver with respect to cost sharing, and their waiver permits them to charge $25 for repeated non-emergency use of the emergency room. That is the only state that has ever gotten a waiver. It's extremely onerous. Now, I want to say here, they got that waiver that they could pay the $25, and it's for the new adults for repeated non-emergency use of the ED. That is the only state, and you can see they have to have a control group, and they also have the co-payments are waived if you call the nurse hotline in advance. That is the only state that has ever gotten permission to charge more than would otherwise be permitted by federal law. And again, CMS looks at cost sharing and premiums hand in hand. Let's now go to the health savings-like accounts. These are awkward to say the least. Indiana had a health savings-like account, which they call a power account, before expansion. And I should also say about Indiana is CMS has articulated that the onerous rules that they permitted Indiana adopt were permitted because Indiana had them in place under a waiver before they expanded. Most state officials don't buy that distinction, quite frankly, but CMS has stood by it that Indiana was a special case. So question whether if Kentucky comes in and asks for everything Indiana got, whether or not CMS would permit it. They certainly negotiated hard with Montana, and again, if you compare the two waivers, you'll see that the Montana waiver does not go as far in terms of premiums and copays and penalties. So in Indiana, this power account is where the individuals deposit their premiums or their contributions. The state puts in the additional amount, and that covers the cost of services. So what Indiana has done, and states toy with, but generally aren't as excited about anymore, is created an HSA-like account in the context of Medicaid, where we can't have high deductible plans. So in and of itself, an HSA-like account doesn't change the rules for Medicaid beneficiaries. It's simply an additional mechanism by which to charge premiums and create incentives and disincentives. Arkansas, I'm not even going to bother explaining because they found it cost more to do than it was worth it, and so they abandoned it. So one more comment on Indiana, again, because of the interest in Indiana. Indiana reports that 95% of individuals with incomes above 100% of the poverty level are regularly making their contributions. Now, if assuming that's an accurate number, the 95%, in some cases it may well be, and maybe it's in many cases, a third party is paying the premium. Because under the Indiana waiver, a third party, a hospital, a health plan, a foundation, any other charity can pay the enrollee's premium obligation and prevent that 6-month lockout. So I think that that's one of the reasons that they may have such a high payment rate. One is it's a huge penalty. 2, a third party can pay it. And 3, they have a long history of using it. Interestingly, Michigan uses a contribution system as well, and there I think it's less than 30% are making the contribution, and of course there in Michigan it's not tied to disenrollment. So that's another differentiating factor, but there's a much lower payment rate in Michigan than in Indiana, although in both cases data is still coming in. Let's look at healthy behavior incentives. And this is an area also of great interest. A lot of it is, skin in the game and personal responsibility. CMS certainly permits healthy behavior incentives, and you can see the Michigan description here in terms of the incentives, which could be tied to a reduction in copays, a reduction in premiums, or a $50 gift card. The issue with incentives is tracking them. If you tie an incentive to meeting certain behavior standards, CMS is going to want to look at the protocols to see that they're tracked so that they can be applied uniformly and accurately. Let's go to connecting to work. This one comes up all the time. It's the response to, we don't want to provide coverage to able-bodied adults. Now, the fact is that most of the individuals in the new adult group are either working or looking for work or medically frail. But for many people, it's got to be tied to work. CMS is clear. You cannot tie coverage to work. You cannot condition Medicaid coverage on working or on looking for work or going to school or being involved in job training, because it's not consistent with a Medicaid program. Certainly looking for work is a good thing, but Medicaid by its terms is a coverage program, and waivers are only permissible to the extent they further the purpose of the Medicaid program, which is coverage, not work. Certainly work referrals are permissible. Certainly incentives, non-Medicaid incentives tied to work or job training are appropriate, but you cannot condition coverage on work. Let's go to benefits now. As you all know, the state has to provide the alternative benefit plan with all 10 essential health benefits to the new adults. In addition, under the Affordable Care Act, states must provide non-emergency transportation to the new adults and EPSDT to 19 and 20-year-olds. CMS has never waived EPSDT. States have asked to have it waived. They have never waived it. CMS has granted some time-limited waivers for the requirement to provide non-emergency medical transportation. It first did that in Iowa, and it's done it on a conditional basis in New Hampshire. Finally, several states have asked to waive retroactive coverage, right? Because we know that if someone applies for Medicaid and they're found eligible, Medicaid will cover medical bills back 90 days. Retroactive coverage, CMS has, under very limited circumstances, waived retroactive coverage. And they did in Indiana. Okay, let's go to something really entirely different, which is on the next slide. And I don't know that this is in play at all in Kentucky, but let me talk to you a little bit about premium assistance for qualified health plans. And in this situation, the state expands and it uses the Medicaid dollars to pay premiums for the qualified health plan so that new adults can enroll in QHPs in the exchange, in the marketplace. And then Medicaid comes in and wraps the benefits if there are any missing benefits. And traditionally it's actually very few because new adults get the same 10 EHBs, 10 essential health benefits. But to the extent the cost sharing is higher and there's a deductible, which isn't permissible in Medicaid, the state has to come in and cover that. So the state comes in and pays premium and wraps around the cost sharing. States can do it as a voluntary matter at any time, but both New Hampshire and Arkansas have mandatory premium assistance for QHPs, requiring all non-medically frail individuals to enroll or to secure coverage through a qualified health plan. New Hampshire just started it in January. Arkansas has had it in place since January 1 of 2014. And it's working quite well in Arkansas. Lots of issues, and I would say to the foundation, if this is the route Kentucky chooses, let's come back and do a whole webinar just on how QHP, premium assistance for QHPs, work. One other type of premium assistance is discussed on the next slide, and this one is one that I think makes so much sense in theory, but is so administratively difficult to administer. And premium assistance for ESI is the state can require an individual who has access, who's Medicaid eligible. So the individual comes in, they make, let's say, 110% of the federal poverty level, and they're working. But they can't afford the coverage. The state may require them to take up the coverage offered by their employer, the ESI, employer-sponsored insurance. They say is a condition, and you can do this without a waiver. You individual, we understand you can't afford the premium of $75 a month, but Medicaid considers it cost-effective. We will come in and pay that premium that the employer imposes on you, so you can get your coverage through the employer's insurance product, and we will add it back any missing benefits, maybe non-emergency medical transportation, and to the extent the premium and copays are greater than permitted by federal law, we will come in and pay it. It's a very onerous process, and so it makes so much sense, right? Because individuals access to employer-sponsored insurance. Maybe their hours went down. Now they're Medicaid eligible. They can't afford it, but they used to have it. They can stay on it, and we're keeping employer dollars in the game. The problem is administering it so that the state can determine for each Medicaid-eligible individual with access to ESI, what's in their ESI, what's the premium, what is the cost sharing like. New Hampshire abandoned it. It just wasn't worth the time and the money they were spending to administer it. And Iowa still offers it. Rhode Island has a relatively successful program, but it's a tough one. Okay, so this concludes the first part and really the bulk of what I wanted to talk about. What I've put on the table are alternative expansions or the features of alternative expansions, trying to call out Indiana, but we've picked from all of the 6 that are highlighted in that earlier map. The next couple of slides I just want to go through quickly, because when you talk about Medicaid reform, yes, the expansion pathway is certainly a reform element. In other words, is this, we think it's reforming Medicaid to have more personal responsibility. But it's also about payment and delivery reform. And so we put on the next couple of slides, and these are really a flyover, and if we could just flip. We looked first at some of what's going on in the states, and there are a lot of states we could have pulled out here. We pulled out Minnesota, who's really moved into accountable care organizations. Like Kentucky, they use Medicaid managed care, and they're requiring through their contracts with their MCOs that the MCOs use value-based purchasing and shared savings with the accountable care organizations. Arkansas has done something really interesting, and theirs is multi-payer, and Medicaid, as well as in the commercial sector with their QHPs, they've moved across the board to a multi-payer episodic payments. But across the board, if you look at what we put in the 4 bullets on the top, this is what states are looking at to reform their Medicaid Medicaid program. And I think this is so critical, which is as Medicaid becomes a major player in the health insurance continuum, the more Medicaid can align with commercial payers and state employees, the more leverage the state has and the more ability the state has to drive reform, and the more continuity of coverage is enabled across payers. So let's just go to the next slide. Managed care. We put this out because you look at the statistics. Managed care is really where states are going. I don't need to say that in Kentucky. And the states have increasing ability and increasingly are taking advantage of it to impose conditions on their managed care plans through the managed care contract. And if you look at some of what Michigan does in terms of value-based purchasing, in terms of population health, in terms of use of health homes, you'll see the different ways you can use the contract to bring payment reform down through the plan and to the provider and the community level. And then finally, and I think this is the last slide coming, if you just flip it, is two more. We looked at all the states, go back one, all the states that are using patient-centered medical homes and ACOs in terms of reforming the Medicaid delivery system. Again, this is primarily about coverage, but when you talk about reform, it really doesn't start with coverage. It starts with coverage, and then it's about leveraging coverage to improve access and drive high-quality, cost-effective care. So let's flip to the last one in this section, and we see here that 7 states have DSRIP waivers where the waiver dollars are funding delivery system reform, and Virginia's about to submit one. Washington's on the verge of approval. Arkansas's on the verge of approval. So we're probably at about 10 states before the end, well before the end of the year. And then we could also do, and we didn't do it this time, we could show you the SIM grants. But again, the point is, talk reform, it's more than just coverage, but it starts with coverage. Because if you don't have coverage, you can't, it's much harder to reform the system. So last section, and then I want to open it up for questions. You know, we keep hearing from states or from state officials that they're going to use a 1332 waiver, State Innovation Waiver, to expand Medicaid. Now, I'm going to walk you through this waiver at a very high level. And if you want more on 1332 waivers, we've done multiple webinars for the RWJF State Health Reform Network. If you go on their website, reams of material. But let's just say right at the outset, the 1332 waiver is not a Medicaid waiver. It is a waiver of provisions of the Affordable Care Act. 1332 did not provide further authority to waive the provisions of Medicaid. So anything you want to do with Medicaid, you want to charge higher copays, you want to charge premiums, it can only be done through an 1115 waiver. Now, a state could think about huge, sort of rethinking your whole system and do a 1115 and a 1332. But 1332 is not a vehicle to implement an alternative Medicaid expansion. So let's go to the next slide and talk a little bit about what 1332 is. Now, a 1332 waiver is authorized by the Affordable Care Act. It does not go into effect until January 1 of 2017. But of course, as you all know, to get a waiver, if you really wanted to do a waiver on January 1 of 17, you'd have to start pretty soon. And, you know, there are a couple of states, and I'll come to that are thinking about 1332 waivers. So you see right here, we underline that states cannot waive Medicaid rules through a 1332 waiver. Here's what they can waive. It's in Section 1332. You can waive the individual mandate, so you could modify or eliminate tax penalties on individuals who fail to maintain health coverage. So you could get rid of the individual mandate. You could get rid of the employer mandate, which likewise imposes penalties on large employers who fail to offer affordable comprehensive coverage to full-time employees. You can waive benefits and you can waive subsidies. So you could waive, we talked about the 10 essential health benefits. You can waive aspects of the benefit requirements, and you can waive subsidies. So you could say, right now individuals who purchase coverage in the exchange and have incomes below 400% of the federal poverty level are eligible for a premium tax credit to reduce their premium obligation. And that has a value. And individuals below 250% of the federal poverty level get a cost-sharing reduction that reduces their deductibles and copays, and that has a value. And if you were to waive it as a state, you are entitled to take that money and reuse it to enable coverage. I'm going to come back to the reusing point. So you can change benefits, you can change or waive subsidies. And finally, you can waive the exchange. You don't need to have exchange. You don't need to have a state-based exchange. You don't need to have an FFN. You could decide to use an entirely different approach to accessing and enrolling into coverage, and do it outside of any exchange or marketplace model. Now, this tells you what you can waive. There's certain things you can't waive, like guaranteed issue. So you can't waive the provision that says no one can be denied coverage because of a pre-existing condition. And you can't waive the requirement that says you can't charge someone more because they had a pre-existing condition. So guaranteed issue and all of the rating rules cannot be waived. So if you want to waive something, the first thing you have to do under 1332 is go to the statute and say, can it be waived? There's a huge caveat which comes in the next page. And this is what we've been calling the guardrails. You can waive all those things I just talked about, but you have to demonstrate to CMS that you meet the conditions in 1, 2, 3, and 4. And in December, CMS put out guidance that interpreted these 4 requirements, and it's a very strict interpretation. So again, this too is a whole nother webinar. But again, December guidance says these are strictly interpreted. And so the waiver has to provide coverage to at least as many people as would have been covered without the waiver. And the coverage has to be at least as comprehensive. So if you waive the individual mandate, how are you going to show CMS that you're going to cover just as many people? Now, there are alternatives to the individual mandate, but you would have to pick one out and demonstrate that as many people would be covered. And same with, it has to be as comprehensive. If you want to waive some of the essential health benefits, you're going to have to demonstrate it's just as comprehensive, even though you're not complying with the 10 EHB requirements. See, you get a sense it's not so easy. And likewise on affordability. If you want to waive tax credits and cost-sharing reductions and reuse or redeploy those dollars, you have to show that the way you're doing it makes it just as affordable to the same number of people. It will be no more costly than it would have been had you not obtained the waiver. So you can see in 1, 2, and 3 on their face, they're stringent. So all of the things I went through that you can waive, you have to show 1, 2, and 3. And then finally, you have to show that it will not cost the federal government more with the waiver than without the waiver. So let's just go very quickly to the last slide. I know you'll be able to look at these, and these are the 3 states that so far have been looking at waivers. Massachusetts and Hawaii have actually started the process. In both cases, they're seeking to preserve a feature of their insurance market that was really pretty unique, and that ACA, by its terms, would undo that feature, and they want to maintain it. So those are pretty targeted. Minnesota just went through a lengthy task force that's deciding what, if any, 1332 waivers they want. And here I want to say, I've had the experience where I'm in a state and a state official says to me, we need a 1332 waiver. And I say, oh, really? What do you want to do with it? And they say, oh, I don't know, but I need a 1332 waiver. So what we say to states is figure out what reforms you want and then figure out if you need the 1332 waiver to get that reform. You may or you may not. So that brings me to the end of the session. And looking at my clock, we have 15 minutes for questions. And let me turn it back to the moderator to start us on questions.
Hi, Deborah. Thanks so much. Again, Rochelle Seeger with the Foundation for a Healthy Kentucky. So many details, so many slides. I want to remind our participants that you've given our slides to us. They'll be posted on the Foundation's website soon. Everyone will be able to have access to that. But let's go through a few of the questions here that we've received. Let's see. This is a question about medically fragile. In general, how have states made the bar for medically fragile classification? So I guess that they're asking, what does that definition look like?
That's a great question. So there's a definition in the regulations, and it's pretty, that's the floor. So it really takes anyone who has serious physical, mental health, or substance abuse problems. So I don't have it in front of me, so I can't be more precise. So it can't be more onerous than what's in the regulations. Now, the question then is, how is it applied? And CMS has been fine with applying that definition by just raising your hand. If you think you meet that definition, you essentially raise your hand, check a box, and if you were medically frail, you have a choice of the alternative benefit plan or the standard Medicaid. That's the benefit, if you will, that comes with being medically frail. And many states, it may be most states at this point, but it's certainly a large number, have aligned their alternative benefit plan with their standard. So there's no need to have the process because the two are the same. But if they're not the same and your alternative benefit plan is missing some benefits that are in the regular Medicaid, personal care is one. Sometimes states have personal care in their regular Medicaid benefit, but not in the alternative benefit plan. An individual, then there has to be a medically frail process. An individual who needs personal care will raise their hand to be found and be designated or be found or find themselves medically frail. The reason those states do not generally impose a rigorous test is because the enhanced matching dollars follow the person. So if somebody's medically frail and they want the regular benefit package, the state still gets the enhanced matching dollars. So for that reason, many states have said, well, let's just align because the dollars follow the person, and if the person needs the regular benefit package, why make them jump through any hoops? Let's just give it to them, because that's what they need. We're still getting enhanced match. And remember, they don't get personal care just because they want it. They get personal care if they need it. So many states have not imposed a rigorous process or have aligned the two benefit packages because the dollars follow the person. That is, you don't lose enhanced match by someone saying they're medically frail and they want the standard benefit package.
Very good, thanks. This is a pretty specific question. This question is, what is the intersection of 1215B and 1115 waivers in MCO states?
I don't know.
Okay.
1215B is not on the top of my head.
Okay, very good. We'll move on to the next question. Let's see. The next question is, can you speak about Texas waiver that included QI projects?
Well, the Texas waiver is not, as you probably all know, an expansion waiver. So let's be clear, Texas hasn't waived. Texas is one of the states with a DSRIP, and Texas secured that waiver as a mechanism, first and foremost, to preserve supplemental payments. So very briefly, Texas wanted to go to a fully Medicaid managed care program. States which are fully Medicaid managed care don't have the ability to make supplemental payments long. I can explain the rationale, but let's take me by word. They can't use, it's harder to use, it's almost impossible to use supplemental payments. So they got a waiver. It's framed as a Medicaid transformation waiver, a DSRIP waiver, and they took the supplemental payments, and they're now using that money to fund a multitude of transformation initiatives in that state. In fact, so many that CMS has said they will never allow quite so many, and they want more focused transformation initiatives. But it's a way to bring down additional dollars into the state to transform the Medicaid delivery system.
Great. Thank you. The next question is about the dental exclusion. What is the rationale for punishing enrolled via the dental exclusion?
Oh, well, first of all, let me just say, you're going to have to ask the leadership in Indiana for the rationale. I can only tell you that it was acceptable to CMS as a matter of law because vision and dental are not required benefits, either in old Medicaid or for the new adults. And therefore, so long as the state provided the basic benefit package, the alternative benefit plan, it was optional whether or not to offer dental and vision. And the state decided that as an incentive for individuals below 100% of the federal poverty level to pay premiums, they would tie coverage of dental and vision to payment. Beyond that, I can say no more.
Very good. Any concluding thoughts you want to make? And then I'll have two final questions for you, and then we'll conclude our 1-hour webinar for this afternoon.
No, I mean, I think it's always frustrating when we can't have a dialogue. So I'm hoping folks pose questions for the issues that are of biggest concern. But, you know, I'm happy to jump back on with particular questions as you see how things play out in your state.
Deborah, thank you so much for that. Let's see, there's a question about stakeholder involvement. Is there a requirement when seeking 1115 or 1332 that states must include stakeholder involvement?
Yes, and it's in the regs, specifically at least 30 days in advance. There has to be a public hearing. The waiver application has to be posted. If you have Indian tribes, you have to start 60 days in advance. It's a little bit looser in 1332, but they say they're going to track the 1115. The broader the request under 1332, the more public hearing and public notice requirements apply.
Very good. And let's see. The last question that we have for you has come from a number of our participants. Where can people go to learn more? They're interested in two things, finding higher level, so maybe like a one-page summary of things, and they're also looking to dive deeper. I know you mentioned the RWJF State Reform Network website has some information. Where would you recommend people go to learn more about this extremely complicated and detailed topic?
Yeah, so Kaiser has published on alternative waivers, and it was relatively recently. Manat publishes a Manat on Medicaid, and every time a state gets a waiver, we publish on that. And on 1332 in particular, we've done, I think, 5 webinars, and all of those are posted to the RWJ State Network website, as are briefing papers we've done on the impact of expansion on state budgets, on hospital and compensated care, on the criminal justice system. So that would be my off-the-top suggestion.
Okay, very good. Any concluding comments for us this afternoon, Deborah?
Nope.
All right. Thank you so much for joining us today. Lots of detailed information, lots of places to go to look for additional information. As I mentioned, you've offered to our participants, the slide deck will be available to everyone on the Foundation for a Healthy Kentucky's website. And again, I can't extend my thanks enough to you for joining us today on this call. foundation website is there, healthy-ky.org. All of the participants on this call will receive via their email a link to a post-event survey. We're very interested to learn about what additional questions you have and ideas for future webinars and trainings, so your feedback is very important to us. A recording of this webinar and a slide deck will be posted to the Foundation's website. Again, my name is Rochelle Seeger. I'm honored to be working here at the Foundation for a Healthy Kentucky. Lots of great work to do here in Kentucky. If you're interested in continuing the conversation, another organization here in Kentucky, Kentucky Voices for Health, will be having a webinar on January 28th. The title of that webinar is The Role of Consumer Advocates in Developing 1115 and 1332 Waivers, January 28th. Check their website for additional information. That's Kentucky Voices for Health. I want to thank everyone on the call today, especially you, Deborah, for sharing all the information with us. Have a fantastic afternoon.
Thank you. It's been a pleasure.
Ladies and gentlemen, that does conclude the webinar for today. We thank you for your participation and ask that you please disconnect your line. Presenters, please hold.